Hi, listeners.
Hello. Welcome to the Med Insights Unleashed podcast
With your hosts,
Z
and John. Hi, Zara.
Hi, John. How are you?
We've been very, very privileged with the speakers that we've had on our podcast, and we've got an excellent speaker on liver cancer today.
Yay.
Yeah. And Dr. Pierre Gholam. He's the professor of medicine, Case Western University School of Medicine. And Pierre also is the director of the Hepatobiliary Multidisciplinary Team at the University of Seidman Cancer Center. So I've known Pierre for a long time. He's a specialist, globally world-renowned in liver cancer, and we're very privileged to have Pierre on today to give us an update on where we are with liver cancer.
Thank you, Pierre.
Yeah, thank you. Thank you, John and Zara, for having me on this great podcast. I've actually watched a few of the episodes before. Actually, many people are very much admire, and I found it incredibly informative, and hopefully I can add some value to it today. I think it's important to have some historical perspective on where we are today versus where we were back when I first met you, John, maybe 15, 16, 17 years ago, which dates you and dates me, but that's probably okay, right, under the circumstances.
Let's keep our personal life out of
That's
this.
right, yeah, let's keep it that way, that's true. So up until 2007, by the way, in 2007, the perception was that HCC was not going to be this big thing. This was still a relatively underdiagnosed, certainly underappreciated disease. But up until 2007, there were no approved systemic therapies for HCC. And most of what we did when we diagnosed the patient with HCC was some sort of a made-up effort on the spot to bring everybody to bear and try to help the patient, either through a radiological intervention. I think ablation was pretty well established at the time. Transarterial chemoembolization was still in its infancy, but there was some evidence that it worked, so we might use that in earlier stage disease. And then in 2007, the FDA, based on the data from the SHARP trial, finally approved sorafenib as the first systemic therapy for HCC. And there was a wave of optimism at the time and a thinking that if a TKI, if a tyrosine kinase inhibitor was approved, many would likely follow. And then we had 10 years of complete failure, I would say. Repeated failures of almost every TKI that was used in practice. I'm not going to list all of them, but all of them were tried in phase 3, and almost all of them failed quite convincingly. 2018, almost 11 years later, when the FDA finally approves lenvatinib as a first-line treatment for HCC based on the data from the REFLECT trial, which was an open-label trial comparing lenvatinib to sorafenib. Around the same time, we get the approval of a couple of agents in second line. The first one was regorafenib, sort of sorafenib's cousin, approved in second line based on data from the RESOURCE trial. And briefly, the agency approves Nivo in second line based on data from Checkmate. That approval is later withdrawn by BMS a few years later, so that is no longer an option by itself. But that signaled some degree of optimism that perhaps both in first and in second line, we were going to be able to find new treatments. And indeed, this time, that optimism is justified because in 2019, the Celestial trial finds that cabozantinib is effective in second line, and so that drug is approved. The COVID pandemic, we have multiple approvals. So in 2020, we have the approval of the first immunotherapy for HCC in the form of the combination of atezolizumab, bevacizumab, and since then, we've had 2 additional combos of immune checkpoint inhibitors approved, durvalumab and tremelimumab, based on the Himalaya trial, and most recently, nivolumab and ipilimumab based on the 9DW study.
Okay, so That was great. Very good, succinct pathway of treatment options for patients. Can we just break it down a little bit? So you had mentioned, between 2007, there was pretty much 10 years of a lag time of failures. Care to comment just very briefly, in your opinion, what do you think stemmed for those failures? Was it the type of patients that were enrolled in the trial, or was it the drug? And again, very just briefly.
Yeah, no, great question. I think we've had many conversations over the years about why. I mean, at the time, it was primarily TKIs, right, that were being studied. Why TKIs by themselves failed. It's interesting. If you look at subset analyses for many of these trials, including sunitinib, for example, you will see that in some subsets of patients fare better. Hepatitis C is traditionally the subset of patients where the outcomes are better. And I suspect that the nexus of why a drug fares better in HCC has to do with the potential harm it causes from a liver standpoint versus the potential benefit it affords you from a cancer standpoint. And there has to be that secret sauce of just enough benefit without too much toxicity in order for the drug to be beneficial. And I think that's why sorafenib basically was approved, because it had just enough efficacy without too much toxicity to actually make this happen. And then almost 11 years later, the same thing happens with lenvatinib. The ceiling for efficacy, though, has, as you know, increased dramatically. So now, with the advent of ICI driven therapies, you're looking at a much greater ceiling for efficacy. And because these drugs generally tend to be well tolerated, hopefully a much better safety. So the calculus of where this stands is quite different now than it was in the 2010s, for example.
Can you give the audience background into the liver cancer disease? You've got Hep C, you've got Hep B, you've got different sort of viral infections that impact. But not only that, you've got metastatic disease coming from other cancers. From our other speakers, they talk about mets to the liver. As a liver expert, can you talk about the disease itself?
Sure. Yeah, absolutely.
And
Zara, did you want to? Yep.
yeah, no, and I was going to say, and the non-viral component as well, because you have both the viral as well as the non-viral, so that would be
Of course, yeah. So that's obviously very important to understand the cancer. You have to kind of understand why it happens in the first place. So that is undergoing a pretty dramatic shift, I would say, worldwide, but perhaps nowhere more dramatically than in North America and in Europe. Up until 2017, the burden of liver disease in general, and HCC in particular, was largely driven by hepatitis C infection.
Yeah.
Today, hepatitis C infection is a very small sliver of this problem because beginning in 2010 and all the way out to the late 2010s, we developed treatment that universally cure hepatitis C. So hepatitis C is a universally curable illness. No one should have hepatitis C today that you've actually diagnosed. And as a result, the burden of chronic hepatitis C has plummeted. What has replaced it is two conditions: the explosion of metabolic dysfunction associated steatotic liver disease, or MASLD, as we like to call it these days, and of course, alcohol associated liver disease, which is at an all-time high. Americans have never consumed more alcohol per capita than they do today, based on NIAAA statistics. So I think that's the background in which you still see HCC, now primarily driven by alcohol and MASH or MASH.
Can you explain that, MASH?
Of course, yeah. The bane of our existence if you're a liver doctor. So MASLD, which is AKA fatty liver, the bigger category, the umbrella category, is a condition that affects a whopping 1 in every 3 Americans. That's right. 110 million Americans have fatty liver disease. That and any other condition pales in comparison, right? But only about, we think, somewhere between 3 to 8% of these folks develop a more progressive condition called MASH. which stands for metabolic dysfunction associated steatohepatitis. Now, that is still easily 10 to 20 million people. That's a lot of people, right?
Mm-hmm.
And of those, predictably, about 25% go on to develop liver cirrhosis, and 1 to 3% per year end up developing liver cancer. We can easily see why a main cause of liver cancer in the background is actually fatty liver disease. One very peculiar thing about MASH that we've learned is that you can develop HCC without having MASH cirrhosis. This is really concerning and difficult to diagnose, but very important to know too. And there's a lot of data emerging on this right now.
As a hepatologist, you see this even before an oncologist. So can you explain your role in the paradigm of treatment so patients understand who they're going to and what the role of a hepatologist is? Because you look after these patients for a long, long time.
Sure. Yeah, absolutely. So, that calls into question how we can best identify people at risk and screen them and survey them for cancers in general and HCC, liver cancer in particular. In hepatology settings, by the way, there are only 900 of us nationwide. We are the smallest subspecialty in medicine, true story. It is pretty well established what the standard for screening and surveillance is. It's typically an ultrasound and a blood test called AFB, which has its liabilities, but is usually easy to interpret every 6 months. That paradigm may be shifting to blood-based markers of cancer. More on that. That's an entire podcast we can talk about, but that may improve compliance and everything else. In other settings, in primary care, family practice, even general gastroenterology, and certainly in other cancer settings, this paradigm of screening patients and identifying those at risk is not well established. And unfortunately, as a result, we think only 30% of people at risk actually end up getting screened. Imagine if only 30 women at risk for breast cancer were getting actually mammograms and other tests, right? So we have a lot of work to do there for sure.
Yeah. So why the screening rate so low? Like, is it resources, lack thereof?
All of the above, right? So one reason is you are asking the patient to have blood work and show up for an ultrasound. These are expensive tests, right? Especially the ultrasound. They require mobility. They require a copay, usually in the U.S., where healthcare is not free, right? They require some time taking away if your busy work schedule to do this. A simple blood test, if that were an adequate substitute, would be a much better test, in my opinion. But the bigger reason, honestly, is that people at risk, which are people with advanced fibrosis or cirrhosis, are not identified by their doctors in the first place, so they are not targets for screening. So, because, of course, we don't do universal screening for liver cancer, right? We only do targeted screening.
Mm.
So given the rising incidence and the staggering numbers that you just mentioned, and again, this is not just for the US, but it's global.
Sure.
In your opinion, are there, what kind of changes need to be made in terms of healthcare systems and guidelines, perhaps?
Guidelines for screening and surveillance were just updated, not even a year ago. It is a voluminous document that I advise anyone listening to this podcast to listen to, and there are some abbreviated versions. The emphasis in the document is on identifying people at risk, which typically means people who stand a greater than 1% per year a chance of developing HCC. So that includes, of course, cirrhosis, hepatitis B, most categories, because of course hepatitis B can give you cancer without cirrhosis. Interestingly, the stuff I just mentioned before, MASH without fibrosis causing HCC, does not quite make the 1% cutoff. So it's not included in the guidelines for screening, right? So you see these patients all the time, but not screening them was not in any way negligent because it's not actually part of the guidelines. What can we do to make this better? I don't know. I mean, you two have a long experience in developing drugs and doing clinical trials. Maybe you can tell me. I'm not really sure. I think a blood test would be a step forward for sure.
Yeah, definitely. There's been a lot of controversy over biomarkers, and that's other area. We in our trials that we did in the past, it was very controversial as to which biomarker. You did mention alpha-fetoprotein, AFP, as being probably the one that's most likely used, but still it has got its limitations. Maybe you can talk about the biomarker.
Absolutely, yeah, absolutely. So AFP has very, very significant limitations, so much so that AASLD, the American Association for the Study of Liver Diseases, which is our national liver organization, actually scrapped it from the guidance one or two versions of the guidelines ago because it deemed it to be too low sensitivity and specificity to be included. And so it basically said you only need to do an ultrasound every 6 months. Now, that created a significant backlash, for lack of a better term, and now it's back listed as something you should consider. AFP, of course, can be elevated for a million other reasons. If you have testicular cancer, for example, your AFP will be high. You can have inflammation in the liver, non-specifically, that raises your AFP. It is a terrible test by all accounts. So it is not only a matter of ordering the test, it's knowing how to interpret the test, which is much more important. For example, a delta AFP over time is much more meaningful than a number that's been the same for a long time. If your AFP is 20 and now it's 100, that's much more meaningful than an AFP of 100 that's been there for like 3 years, if that makes sense. So I think there's that. There are other, of course, proprietary biomarkers for HCC that are there for the purpose of screening. The most well-known, of course, is GALAD, which includes proprietary components of compounds that are or molecules that are thought to be involved in the pathogenesis of HCC. And of course, that is the subject of a very large, the largest NIH-funded study called TRACER, which is aiming to see if GALAD can substitute for the standard of care, which we participate in too. So
Is that a blood test?
that is a blood test, indeed. That is only a blood test, no imaging needed.
So again, it really helps in terms of cost and burden onto the healthcare system, right? And it's easier for patients as well, and they don't have to wait.
I think so. I mean, that's the idea, right? Is to simplify screening so that people don't have to do two things every time, and they end up doing neither, right? Which is even worse.
Pierre, we've traveled into Southeast Asia and Japan. Those countries have a significant surveillance program. Is that feasible in the United States?
Yeah, absolutely. Well, I mean, as you know, I have a ton of admiration for our Southeast Asian colleagues who do a fantastic job, both on the treatment side and on the screening side. I mean, Japan is, of course, the exemplar of such a place, right? Typical Japanese rigor and scientific method, really apply. And so the Japanese have very effective screening and surveillance. Japan is unique in Asia in that the epidemic of HCC was driven by hepatitis C, not hepatitis B.
Right.
They're just about to eradicate hepatitis C too, so that will do them a lot of good. But other Asian countries are not the same, right? They have a very much a hepatitis B driven epidemic, and some have made tremendous strides. Taiwan would be the most obvious example where universal vaccination was first implemented, but Singapore, certainly Korea, a lot of these places have very high uptake of screening and surveillance. Can we do the same in the US? I suspect not. We have a very different healthcare system. The way healthcare is delivered is very different here. We have multiple payers. So I would venture to say that it is very difficult to replicate all these models here.
So you really need to have a national program, which is not in the
Yeah,
books.
I mean, not sure how you make that happen, but yeah.
Can you just explain the difference between the B and the C and hepatitis, and which is more prevalent and how it's transmitted?
Sure, I'll try. Sure. So hepatitis B is the most common cause of liver disease worldwide, although some argue MASLD and MASH may have overtaken it. But of the estimated 370 million people who have hepatitis B, something like 85% of them live in Asia, right? In specifically Southeast Asia. So there are many places around the world, including mainland China, for example, where 1 in 10 people are hepatitis B surface antigen positive. Hepatitis B is a slowly progressive disease that can cause life-limiting or life-threatening complications in about 30% of people over their lifetime. So clearly a very bad disease that we want to treat. And the treatment is there. It's in the form of a nucleoside or nucleotide analog, and it is incredibly effective. It suppresses virus in 90+% of people, and that reduces their lifelong complications by over 50 to 60%. Hepatitis B is not curable yet. That's coming. We should have, maybe if we have a podcast in 6 years, we'll tell you all about functional cure of hepatitis B, but that is definitely coming. Hepatitis C, of course, is a solved problem. The only remaining issue is finding people to cure. And in fact, Egypt, Mongolia, and the Republic of Georgia will be eradicating hepatitis C in the next 1 or 2 years. So that is a real thing, right? That's
It's
happening.
amazing.
Sorry, so you actually bring up one other area that I was thinking about was liver diseases caused by aflatoxins. So I did some voluntary work in Kenya a few months ago, and it was brought to my attention again, a country that is primarily, Hep B virus driven HCC. But then I was kindly corrected to say actually the rates of liver cancer as a result of aflatoxins
Right.
are very high there. Could you just briefly elaborate on that, please?
Right. You should probably do a podcast on your work in sub-Saharan Africa. I would listen to it for sure. So it's actually a bit of a misunderstood thing. So in the U.S., aflatoxin toxicity does not exist, of
Right.
course, because grain is usually stored adequate. So aflatoxin, for those who don't know, maybe most of this audience knows, is the result of poorly kept grain,
Yes.
which actually molds and ends up having this fungus that grows on it that actually has a known carcinogen, a WHO carcinogen called aflatoxin. And aflatoxin puts you at high risk for developing many cancers, but primarily HCC. There are many trains of thought about why aflatoxin sets you up for cancer and who gets cancer. And the prevailing theory is that you need to have some other liver disease for it to happen. So true, hepatitis B in sub-Saharan Africa is the main driver of liver disease and cancer. But aflatoxin, for it to cause cancer, usually happens layered on top of hepatitis B infection, if that makes sense. There are very few other places other than sub-Saharan Africa that still have aflatoxin issues. I think rural China, some places may have aflatoxin, but certainly in other countries in Southeast Asia and in the U.S., Canada, and Western Europe, you're not going to see a lot of aflatoxin toxicity.
Thank you for explaining that because again, one interesting part was, trying to get clinical trials specifically to look at drugs that can address, because again, when we look at clinical trials and they're investigating certain drugs, you look at the underlying disease of patients, Hep B, Hep C, non-viral. Aflatoxin is one area, again, because it's primarily within sub-Saharan countries. So it'd be
Right.
interesting to study whether a drug could actually have improved efficacy for that specific subset of patients
Right.
that, express the aflatoxin. If any pharma companies are listening to this could be a good clinical trial for them.
Yeah. And there's been wonderful, I would be remiss if I did not mention this. I mean, there has been some wonderful work to raise awareness of HCC in sub-Saharan Africa, which historically has been forgotten. So I'm happy to highlight two people. Ed Kim apparently was just in sub-Saharan Africa doing ablations, and what a wonderful thing for Ed. I would expect nothing less of Dr. Kim. And then, of course, Lewis Roberts,
Yes.
who is at the Mayo Clinic, has helped tremendously in developing HCC treatment programs, mainly in Ghana, but
Yeah.
also in other sub-Saharan African countries. So there is work being done, just not by pharma. Maybe pharma needs to also get interested in sub-Saharan Africa.
Absolutely.
Yes, I've reached out to Dr. Joseph from Uganda Hospital there that was working with Ed Kim, the Mount Sinai team, to actually do a podcast. So I'm just waiting
Fantastic.
to hear back from them. But Ed was kindly got me in touch with Dr. Joseph, and so we're just waiting on a response there.
That would be
That's an
wonderful.
amazing microwave ablation, first patient ever treated. That's crazy.
Yeah. That's wonderful and also sad, that it's taken to 2025 for a sub-Saharan African patient to be treated with ablation, something we've had since the 1980s, right? So, but I mean, kudos to Ed and his team for doing this. I would love to listen to the podcast that talks about this. Yeah.
We'll let you know when we do it.
All right. Yeah.
We're talking about treatment. You did mention that since sorafenib, there was a dearth of failures. Now we've got monotherapy, but the world's changed with immunotherapy and combinations. Maybe you could talk about the recent studies and what that really means to you as a hepatologist and also to the oncologists and the treatment.
Sure. Yeah. So of course the landscape has changed, unrecognizably even in the past 5 years, right? So I think the big, if you want to call it breakthrough, the big change in the way we treat patients happened in March 2020 when the FDA approved atezolizumab and bevacizumab. And that signaled that ICIs were here to stay in HCC and later, by the way, in BTC. That's another conversation worth having. And what's happened since is people have tried other combinations. And, it's interesting. Most of them tend to be effective. Some have gained FDA approval because their calculus for toxicity versus safety seems to meet the agency's standards, and some have not. Some are still in the process, but the two obviously big regimens that have been approved since are durvalumab and tremelimumab, and of course, most recently, Nivo1 Epi3, right? Nivolumab and ipilimumab at the 3 milligram dose. So those are the three regimens that are currently available in first line. I emphasize in first line for patients who have unresectable HCC. That doesn't mean that TKIs are not helpful or useful in that setting. Of course, if you have an immune-mediated condition that is serious and life-threatening, you don't want to give an immune checkpoint inhibitors. These are treatments that could still work and be safe for that patient. And of course, there are situations where patients may have contraindications unrelated to immunity or autoimmunity, or specifically where these drugs are useful. We're making some headway in trying to identify adjuvant therapies. Unfortunately, the excitement that was initially built around atezolizumab, bevacizumab as an adjuvant treatment for presumed cured cancer from the IMbrave 050 study has not panned out. Recently, we were informed that the study did not meet its primary endpoint.
Okay.
And so that's unfortunate. Neoadjuvant remains a very active area of investigation. We could spend an hour talking about this, but some positive data for Emerald-1, for example, Durva, with or without Bev in the setting of a combination with TACE, right? And a lot of others. So all of these are treatments that have been largely taken over by our medical oncology colleagues. I think interventional radiology still plays a role, but at the risk of having someone from IR listen to this and call me afterwards, I would say that role has shrunk a little bit for the interventional radiologist in 2025 versus before.
You've mentioned there's three major combination therapies in frontline. How do you pick the patient for the different regimens that are being approved?
Yeah, you're going to get me into trouble there, but I'll try. So atezolizumab, bevacizumab was the first approved treatment. The data are mature, and the overall survival is clearly in favor of the combination. One thing I will not mention in this repartee here is what the overall survival for each of these agents is, because that would be comparing apples and oranges, right? It wouldn't be fair to any of them.
Right.
But I would say that all these regimens have improved overall survival at the time of censoring for data reporting. They all have fairly similar toxicities, although, for example, the addition of Bev would increase risk of bleeding events, as you all know. So if someone has bleeding that cannot be mitigated, perhaps Bev is not the best option. That doesn't mean that giving Tremi, which is a CTLA-4 and has a lot more toxicity, is not potentially laden with some liability by itself. So you have to pick your patient based on their own characteristics. 90W, the Checkmate 90W, the study that led to the FDA approval of Nivo-IPI, obviously was interesting because in the first 3 to 6 months when the study started, it looked like the Niva 1 IPI 3 arm was tanking, was really like actually had less survival, and then sort of the phoenix rises from the ashes afterwards and things improve. So that implies to me that a very robust patient, perhaps someone who has MASH but no cirrhosis or hepatitis B with no cirrhosis, might be a good candidate for this. This is obviously what a tumor board revolves around. You know, to talk about this for an hour, but I just tried to do that in 2 minutes. So, yeah.
No, thank you. So I have two questions from what you just mentioned. The first one was, what about patients that receive a liver transplant? Any concerns with obtaining the immunotherapy drugs if a patient has received a liver transplant?
Right. Very important and timely topic. So, giving patients a transplant, if they've received immunotherapy, is becoming increasingly acceptable. So, Dr. Tabrizian and the group at Mount Sinai just published data from the Vitality study that shows that that is remarkably safe, including some patients who received their last dose of immunotherapy not long before they get their transplant. Historically, the common wisdom was that you should wait at least 90 days from your last dose of immunotherapy to the time when you transplant this patient. But where people are definitely pushing the envelope, and I suspect that that will be different. Giving somebody immunotherapy after a transplant is still very much out there, not something that most people would do. The evidence for humorally mediated rejection in that setting suggests that that is a potentially fatal and catastrophic situation. So that's not done.
Okay.
Not done for the most part, other than in the setting of clinical trials. It looks like if you wait 3 years and someone recurs that far back, you could give them immunotherapy more safely because a lot of the transplanted cells have chimerized, so they actually have a lot of tolerance to the host, and they may not actually lead to massive rejection.
Okay.
But I would say, in the spirit of being fair and balanced here, that that is still very much out there. That is not something that's routinely done.
Is bridge to transplant is what we're talking about. That's an early stage treatment.
Bridge to transplant is increasingly done with immunotherapy, right? So, because immunotherapy is effective therapy, in the past we used to use, of course, embolization, all hands on deck to try to downstage the patient. And now one of those tools, of course, is immunotherapy. And so if you can prove that immunotherapy is safe up until relatively shortly before you give this patient a transplant, that would be a wonderful addition to how we treat these patients. And I'm not saying we're there yet, just to be clear. I'm just saying that we're making really good strides in understanding how we can do this safely. There was a lot of talk about PD-1 versus PD-L1 and how that might sort of differentially mitigate risk. I think that talk has mostly kind of gone away, or sort of passed. We still don't understand this 100%, but certainly we're making progress there.
So within that progress, the next leading question was for me is around the subset of patients of being treated by immunotherapy. So as what you've just mentioned and what John was saying is how do you pick your patient with all of these different combinations of immunotherapies? Is there a subset of patients that are, primarily Hep B versus Hep C, but now you bring in MASH?
Yeah.
So okay, so I guess my question is, we can't go back. So retrospectively, did these studies do a good job in trying to identify these various patients, or should we be looking forward in terms of clinical trial design and ensuring prospectively that these subset of patients are well represented?
Right. So that's a great question. So of course, when you enroll patients, depending on where you enroll them, your demographics and etiologies fall reflecting that population, right? So if you enroll heavily in Asia, you're going to have, 50, 60% of your patients have hepatitis B, right? And if you enroll in the West, it used to be all hepatitis C, but now it's mostly MASH and alcohol, right?
Yeah.
I guess the question should be, does it really matter? Do you care what the etiology of liver disease is? Isn't cancer cancer, right? Why would it matter if a cancer came in the background of alcohol or MASH or something else? And I have to say, although there are some studies that show that etiology does matter, that perhaps there is a differential response, especially when it comes to MASH, there is also some evidence that suggests that it may not. And so the greatest evidence that shows that MASH patients may be resistant to immunotherapy to some extent comes from this Nature paper that was published almost 3 years ago by Matthias Eichenwalder and the Heidelberg group. Basically, they showed that there is an immune defect created by having steatosis that makes your CD4/8 T cells actually less active in clearing cancer. And so there is some justification for the evidence from Iron Brave 150 and other studies that perhaps these patients respond less well. Of course, there have been analyses of, for example, Himalaya, the Durva-Tremi trial, where it shows that all these drugs work equally well across different
Mm.
etiologies. I mean, I think the question is, can we do a better job of identifying patients based by etiology and studying them? No doubt about it. But sometimes the demands of having a target enrollment at a certain time make it such that it's
Right.
kind of difficult to do that.
Can you describe? We haven't got a visual. You've got a great visual behind your head that in your office
I like that.
of the GI tract, but including the liver. Can you describe what a liver that's got MASH looks like for our patients listening versus what a healthy liver looks like and what a
Let me
cirrhotic liver looks like?
Sure. Let me make sure I understand the question correctly. You're asking what a person's liver with MASH basically looks like? Uh,
Yes.
so normally your liver stores fat in the form of triglycerides. You should not be storing more than 5% by weight of your liver in triglycerides. Your liver does not store cholesterol. It only stores triglycerides. So fatty liver means a lot of triglycerides in your liver, which is what you eat when you eat foie gras, right? That's why it's fatty and I think tastes very good. But anyway, that's an aside here.
That's an aside.
Well, yeah, maybe you can cut that out of the podcast. But anyway, yeah. Anyway, so what happens for reasons we don't fully understand, to be honest. They don't just have to do with the fact that you gain weight or become obese. That's only one part of this, where you start accumulating more fat in your liver. And we actually have ways to grade this, both on a pathological specimen and with various non-invasive techniques, including this technique called CAP, where you can actually measure how much fat there is in your liver without sticking a needle in the patient. And the vast majority of people, even when they have large amounts of fat, do not suffer ill effects from it, right? The majority of people with fatty liver do not die of liver disease. It is an exquisitely strong indicator that you're at pretty high risk for stroke and heart disease. So, which is why, the movement, sort of the general health movement in medicine now is to talk about cardiometabolic risk. Don't talk about cancer. Don't talk about heart disease. Don't talk about diabetes in a silo. You have to talk about the whole person, right? Cardiometabolic risk. If you address that by medications, by diet and exercise, by whatever intervention you want, bariatric surgery, etc., you're treating the whole thing, right? You're not just treating one thing. But essentially, in some people, a small subset of people, less than 10% of people, buildup of fat triggers inflammation in your liver. And this inflammation progresses. We think every 7 to 9 years, you jump from one stage of fibrosis to the other. And so it could take you 2 decades or 3 decades to get there. But in selected patients who are at risk, you develop cirrhosis. And then once you develop cirrhosis, every year you have a 1 to 3% chance of developing HCC, which is why we're talking about this today.
Question. GLP-1s that are out there, the Wegovy's, what impact are they having on the fatty liver? If there's a basic weight reduction process going on,
Yeah.
do
Boy,
we know the
that's
long-term effect?
That's a 3-hour podcast. That's all I do for a living these days, right? So we should probably have a separate podcast.
I was going to suggest that. Okay,
Yeah.
so John, great lead up question. Because now
John is sidestepping us here. Yeah. So, but I memean, very briefly. So, GLP-1 agonists are just one class of this broader group of drugs called incretins. There are not only GLP-1s like semaglutide, the one you mentioned. There are dual GLP-1s and GIPs like a medicine called tirzepatide, which is also that would be Mounjaro and Zepbound. That's also on the market. And there are, believe it or not, drugs that actually agonize 3 different targets. So they call these triple Gs, and that is something that's not currently out there. But those are drugs that in a very high percentage of people cause very significant weight loss, up to, in the most extreme circumstances in subsets of patients, a quarter of your total body weight after a year.
Wow.
I would love that to happen to me. So, but of course, this is associated with some metabolic improvement and potentially some liabilities. So these drugs have side effects, including gastrointestinal side effects. And of course, you're not only losing fat, remember that's an important detail, you are losing muscle mass. So when you actually lose a quarter of your body weight, you also lose about 31% of your total muscle mass in the process. And I think if we're going to have a thoughtful discussion about this, we should include all this. But they do play a key role in treating metabolic conditions, including MASH. And there's already plenty of clinical data to support this.
We just have to have a podcast on that, Pierre, really. It bugs me, actually, because in some regards, it's great. You see this amazing turnaround in people that you've known before. But in some cases, you get the grey look and there's too much weight loss. And there is so many things that we don't know about the long term. This probably is not a really good one for Wegovy, but all those other ones, the Mounjaro. But it's an interesting field that when you see someone and you look at the results, it's amazing.
Sure. Yeah. I mean, there are no miracle drugs, is how I would conclude this. There are drugs that can help you live longer and better. And these, probably in the appropriate patients, are some of those drugs. I will add also that there is a tremendous level of interest in GLP-1s, or this class of incretins in general, as cancer chemoprevention agents. In fact, already there is pretty strong evidence that these agents are far more cancer chemopreventive than most of the interventions we've had in the past. There's also, on a completely separate topic, these drugs seem to be highly effective in treating alcohol use disorder. They reduce craving for alcohol, gambling use disorder, opioid use disorder, so addiction in general. There's now pretty good evidence that they actually are far more effective than anything you. So we should have a separate podcast.
I was
going
to say, yes,
talk about all this. Yeah.
I'm sure the listeners will be waiting for this one, Pierre.
All right.
Sorry. So just to bring our subject back to liver cancer, we speak about, and again, it's important for our listeners to be aware of treatment modalities. But I think the other side of it is you add more treatments, you're going to have side effects. So can you just briefly maybe just mention, some of the impacts or impact to these various therapies in terms of side effect management, and then, quality of life. Patients want to receive treatment, but then again, you have to weigh the quality of life versus treatment modality.
Sure. Yeah, very important. So obviously, now that you have ICIs and TKIs, although ICIs dominate, and BEV, of course, which is neither an ICI nor a TKI, you have sort of a broader spectrum of side effects. For ICIs, of course, in the vast majority of patients, these drugs are remarkably well tolerated. Now, as I always tell our fellows when when our fellows round with us, we see a lot of patients who have immune-mediated adverse reactions, IMARs, right? And the fellows always ask me, boy, these drugs cause a lot of these terrible side effects. But in fact, what they don't understand is that for the total number of people who are receiving an ICI, the number of people admitted for complications or side effects is a very small sliver, maybe 3 to 6% of all these patients. The liability with ICIs, of course, is that if you do get a serious IMAR, it's usually potentially life-threatening or fatal, right? So the big ones, of course, are immune-mediated hepatitis, which is very much our wheelhouse. We see a lot of patients with melanoma, lung cancer. Of course, there's multiple indications who get this. Immune-mediated colitis is a very serious complication. And then the others, the rashes, all this stuff, you tend to be able to manage pretty easily. Of course, with TKIs, which we have a longer experience with, the main side effects have to do with VEGF-driven mechanism of action. So high blood pressure, skin stuff, including hand-foot skin reaction and other things. Of course, asthenia and fatigue are big ones for people who take a TKI. And for BEV, of course, it's all bleeding, right? So anything from epistaxis, which is a very common problem, all the way to life-limiting or life-threatening variceal bleeding. All of these things can happen. So I think a clinician who's treating patients for HCC with all these agents needs to be very well versed at not only identifying, but also treating. So we have pretty good guidelines now for how to treat immune-mediated adverse reactions with prednisone, how much to give, for how long to give it, but that still happens. That's still a problem that sometimes, people could be educated about some more for sure.
To that point about education, can you just expand on the gastrointestinal side of the side effect with ICI?
On the gastrointestinal side effect?
What's happening? Because you talk about it, but
So ICIs will mainly cause you gastrointestinal side effects if they cause immune-mediated and organ injury. So either colitis, which is really bad. Immune-mediated colitis is like the worst case of ulcerative colitis you will see usually. It does usually require interruption of the drug, sometimes permanent discontinuation, and it's a serious problem. The other one that can happen, although I have personally never seen it, is immune-mediated pancreatitis, which can also happen. And that can cause symptoms similar to, garden variety pancreatitis. It's pretty rare to have other specific GI side effects from the ICIs we use, at least. So most of it will come, from injury to an end organ that then leads to symptoms. I've never seen. I think there's been immune-mediated gastritis described. That has to be exceedingly rare. I've personally never seen it. Yeah.
okay. Thank you very much for that, Pierre.
John, maybe I'm conscious of the time. And, John and I always ask our guests for, 3 main key takeaways from having the conversation with us that patients can kind of leave with in their minds. I know we've talked about so much on here, and we will bring you back to have another discussion about GLPs. But what are your kind of top 3 key takeaways for patients here?
Well, I think I would be remiss if I didn't end on a note of optimism. We've come a long way when it comes to treating liver cancer. Liver cancer used to be a 9-month overall survival proposition, and now we think north of 1 in every 5 patients live 5 years or more with metastatic liver cancer. We're not even talking earlier stages of liver cancer. So if you are diagnosed with liver cancer, especially if it's early, and quite honestly, even if it's metastatic, do not think that this is a very short life expectancy proposition. You could live a reasonably long and good quality of life with the available treatments that we have, assuming you get the care that you need. So that would be the number one. I think optimism about not only where we are today, but where we will be probably in 5 to 10 years. The second point is I think we need to raise awareness about not only liver disease, but liver cancer. We don't nearly do enough to inform our patients about what the underpinnings of liver cancer are and why they should care, right? You hear a lot of people talk about skin cancer and avoiding the sun and putting SPF sunscreen on, and breast cancer and colon cancer. We have increased awareness of young people getting colon cancer these days. All of this is out there. Have you heard anyone talk about liver cancer out there? Is there any advocate for liver cancer that's out there? So I think it's our collective mission to also talk more about this. And the third thing is, I think you need to have a more holistic approach to the person, not just the cancer. I think the whole survivorship movement kind of in a sense, aims towards that. But a person is not their cancer. A person can live with their cancer for a long time, and you still have to care for the person. And I don't know how to pin that down in more specific terms, but it's certainly something we need to do better at. So
I have one last question to you, because Zara and I talk a lot about multidisciplinary teams, and you're the director of the Hepatobiliary Multidisciplinary Team at Seidman Cancer Center. What is your role as the director? What do you actually do at that board meeting?
okay. Yeah. I mean, this is going to sound like an airing of grievances, but so my role, so we started the multidisciplinary hepatobiliary tumor board in 2009. I would venture to say that it was one of the earliest, perhaps the earliest liver-specific tumor board. When we started it, there was not a whole lot of enthusiasm. People would say, there's nothing that you do today that would require the presence of 5 or 6 people. Of course, now it's completely different. So what do you do? Anything from accepting any case that would come our way, whether it's from our hospital system or anybody. We get cases presented. Argentina, we had a case presented 2 months ago. Pakistan, we had a case presented not so long ago. And our decisions, so we collect the data, we review the case, and we issue non-binding recommendations to the clinician that we are in turn not obligated to. It is the onus is upon them to implement this. We can't force them to do it, of course. We provide the expertise and, in an ideal world, what the best course of action for that patient is. I think that's a good summary of what we do. Yeah.
Yeah. Excellent.
Thank you.
Excellent. Thank you. So, Pierre, it's been brilliant. It's been a long time getting you on, but we're so grateful that you gave the time today, and
Yeah, thank you.
and our patients would definitely thank you. It's been a great subject. We haven't really done a liver overview and touched on many of the other subjects, and it looks like you're coming back to
Yeah.
do
Sure.
a couple of more.
Happy to do it.
Okay, so we wish you well for the rest of the week. Can't thank you enough, mate. And
Thank you, Pierre. John,
Pleasure meeting you, Zara. Yeah.
you
Yep.
too. And we look
All right.
forward for the next one on MASH and the GLPs. Stay tuned.
All right. I love Vancouver too. That's a great place. Yeah. Hey,
I think, John, we may have to have an on-site
you
podcast
should.
meeting.
I mean, Vancouver is no New Jersey, but
No, it's not.
just kidding. All right.
It means we're so
I'm
friendly.
stopping the recording.
We need
MedInsights Unleashed disclaimers. This podcast is for general information purposes only and should not be considered healthcare advice in any way. The podcast is not intended to replace professional medical advice. The use of the information and material linked to the podcast is at the user's own risk. MedInsights Unleashed is not responsible for any losses, damages, or liabilities that may arise from the use of the podcast. Importantly, please consult your healthcare provider for individualized guidance and treatment. Thank you, and we look forward to you being with us on the next MedInsights Unleashed podcast.